Hello and welcome to this evening's webinar. This evening we're going to be having a talk from the team at Total Orthopaedics, giving us a unique perspective on the current state and situation in the NHS, and looking at a variety of interventions for different case studies for different patients, and how this has been affected by the COVID and the post-COVID period. So a really unique perspective that you can see where the patients are going to be going to and what trauma, post-trauma interventions that are available to them. So before we start, we're just going to do a little bit of housekeeping. So first of all, you can communicate with us through the Q&A function or the chat function. So any questions that you have for any of the speakers, they can go through that Q&A function, and then we'll be able to pass those on to them. We do get a lot of questions. We do our best to answer all of those, but it's not always possible. So we'll do our best with those. All the sessions are recorded, so we do get quite a lot of questions about the PowerPoint file and that sort of thing. So you can always re-access those if you want to through the Össur webinars site on each of our regional websites, or Össur Academy through the Össur Academy YouTube channel. There'll also be e-certificates sent out. They're normally sent out the next day in the morning, and there'll also be follow-up questionnaires. So really appreciate it if you can give us some feedback, potential ideas of other topics and other techniques that you'd like us to cover. So the setup for this evening's session is a little bit different. We actually have 6 speakers from Total Orthopaedics. So we're starting first of all with Mr. Saksena and Mr. Nwaboku, and they're going to be talking about tibial plateau fractures. So I'm just going to give you a little bit of a biog on both of those. So starting with Mr. Saksena, he's a consultant orthopedic hip and knee and sports surgeon for Barnet and Chase Farm Hospitals. He's also Director of Medical Education at the Royal Free London NHS Foundation. Mr. Nwaboku is a consultant orthopedic hip and knee surgeon and postgraduate education lead at the Royal Free London NHS Hospital. We then have Mr. Pinak, and he's going to be talking. He's the trauma and orthopedic surgeon with a special interest in foot and ankle, and he's the lead clinician at Barnet and Chase Farm Hospital, and he's going to be talking about Achilles tears. We do have Mr. Dattani, and he's a consultant trauma and orthopedic shoulder and elbow surgeon at Chelsea and Westminster NHS Foundation Trust, and he's going to be talking about shoulder trauma. And then we also have Mr. Rajiv Bajekal. He's a consultant spinal surgeon at the Royal Free London NHS Trust. He has a special interest in lower back disorders. Now, our last speaker is Dr. Imran Anwar, and he is a specialist consultant musculoskeletal radiologist working at the Royal Free London, and he's going to be punctuating all of these talks with specialist radiological considerations for each of the case studies that the team is going to present. So he'll be popping in and out of all the talks with input from that. So it's a really good opportunity for you to see how the radiologist interacts and supports the surgical team as well. So just remains for me to thank the speakers and then pass over, first of all, to Mr. Saksena and Mr. Nwaboku for the first part of their talk.
All right, thank you very much, Giles, and it's a real honour and a pleasure to be invited by Össur to do this talk. As Giles mentioned, we're going to literally talk about 4 trauma cases that presented during our time or during the COVID pandemic, at the height of the pandemic, and how we managed that. What we'd like to do is present the history, then we're going to show some x-rays. Dr. Anwar is then going to just describe the x-rays just to give you a bit of knowledge about that. And then we're going to put a poll up just to see how the audience would essentially manage that particular case, and then what we actually did. So we'll do that with each of the 4 cases from the different body parts. Now, why are we in this situation? COVID has affected each and every one of us in some shape or form. And at the beginning of the pandemic, our trust was a hot site. All our trauma was being, diverted to what we could have called elective sites, namely RNOH or Stanmore. and we were dealing with the acute sort of COVID cases. But once the trauma started coming back to Barnet and Chase Farm Hospital, there wasn't much evidence and there wasn't much literature out there as to, how we manage as patients. And one of the first papers that come out was published in that Lancet, over 1,000 patients, both elective and emergency surgery. And what the paper reported on, there was an up to 20 or just over 20% mortality rate in these patients, either if they had COVID or if they even didn't come in with COVID, they were developing COVID afterwards. And over 50% of these patients were developing pulmonary complications. Now, this is a multi-center study done around a number of countries around the world. And really, that's what we had to guide our management. So every time we saw a patient, and patients weren't coming into a hospital, they were sitting at home waiting, to be told or trying to manage as best as possible. And we were seeing trauma later and later. But when they did come, we had to manage their expectations. They just didn't want to be there. They wanted to get out as soon as they can. They were worried, just as were the rest of us at that time. So I'm going to start with the first case of this evening. So I'm just going to quickly share my screen here. So this first patient, she's a 63-year-old lady. She's pretty independent. She was out walking her dog one day, and there was a pothole in the park, and she managed to put her foot in this pothole, and she sustained a hyperextension injury. And the following fracture was observed. She was otherwise pretty well. She had no comorbidities, and she'd had a previous left hip replacement in the past, and that was very successful. So just going over to my colleague Imran to just tell us what you think about these x-rays, Imran.
Unmute.
Okay, bear with us a second. We're just going to unmute Imran.
The wonders of
Okay, can you hear me now?
We can, yes.
Okay, so here we have on the left an AP view of the. Can you see my pointer, by the way?
No.
Okay, now.
Yeah,
good.
now we can.
So this is the AP view, and this is the lateral view of this patient's knee. And what you can see here, we can tell this is the lateral side. This is the lateral tibial plateau because this is where the fibula is. So this is the medial tibial plateau. And if you follow the contour of the metaphyses, it's nice and smooth on this side. Whereas on this side, there's a sudden step at this point where it goes out. So we can see that there's a bit of buckling of that cortex here, which gives you the impression that there's probably a fracture here of this medial tibial plateau. On the lateral view, you can see that normally the tibia should slightly downslope posteriorly, but we've got a reversal of that, which kind of fits with a hyperextension type injury. So to appreciate this fracture in a bit more depth and a bit more detail, and to evaluate its extent, it's important to get cross-sectional imaging, which is where CT is the mainstay for evaluating.
Okay, so that's exactly what we got. We can, as you say, the tibial plateau fracture, we need now a little bit more detail about the complexity of this fracture. And I'm going to show this is a 3D CT reconstruction. So Imran, any comments on this?
So on the 3D reconstruction, the advantages of CT here is that it gives us the information that the surgeon really requires to decide on further management, namely whether there is a depression of the articular surface, which in this case there it clearly is, and you can see that the fracture extends also to involve, perhaps there's a split here in the lateral tibial plateau as well, which also changes the management as well. The key here is that the medial side is depressed, so there's a little bit of varus angulation, and that will affect the mechanical axis of the knee. So when this patient weight bears, that's likely to continue, and if left alone, this could potentially end up in a varus deformity in the long term.
Okay, so I'm just going to stop that screen share. So going to really go over to my fellow hip and knee specialist, Harold Nwaboku, and really ask him, how would we be typically treating this kind of 63-year-old, fit and well, no comorbidities? How would we be treating it pre-COVID, and what was the change in management?
Well, I'd like to thank also for the invitation to this meeting, and the first thing to say about this type of injury is it's a very severe injury. We're fortunate that the patient doesn't have any neurovascular, any nerve or vascular damage. And the pre-COVID, this would be a candidate for surgical treatment. And the surgical treatment is to restore the joint line and also maintain alignment. But this is a lengthy operation.
Sorry to just interrupt 1 second. I just need to put the poll up, actually, Giles.
Yeah, sure.
Yeah. So we just launched that. So in your opinion, how should this tibial plateau fracture be managed? So is it brace and plaster, open reduction, internal fixation, external fixation or knee replacement? And then the second question is, if you opt for non-surgical management, which of the following would you use? So is that nothing? Is that a range of motion brace or plaster cast, a knee immobilizer or long leg cast? So we have about 20 to 30% of people have answered. We'll leave it up a little while longer to allow that to come through.
We fully appreciate you may not all be orthopedic surgeons, but it's just to give an indication of what the audience would do in this situation.
Okay, brilliant. People are coming through with those answers. So I'll give it another few seconds. And I'll end that polling, and then it will pop up there. Brilliant. So I'm just going to share that. So we have, how should the tibial plateau fracture be managed? 29% have said brace or plaster. 65% have said open reduction, internal fixation. 5% have said external fixation. And then 2% have said knee replacement. And for the second part, if you opt for non-surgical management, which of the following would you use? Nothing, with 8%. Range of motion brace or plaster cast with 71%. And then 21% saying knee immobilizer or long leg cast.
Oh, do you want to just comment on those statistics?
Sure. It's interesting because those statistics would you expect during the pre-COVID times. And I think I'd mentioned that this is a serious injury and we want to restore the joint surface and maintain alignment. But in a 63-year-old, it is quite a lengthy procedure. And post-COVID, I think we've had to think about how we would proceed, because having a patient undergo a general anesthetic to have an operation, as has already been alluded to by Joyti, there is a risk, and that's a risk that when you discuss with the patient, a number of patients will find that it's difficult to tolerate that risk, and they look for other options.
Okay, so in terms of, so what you're saying is that pre-COVID, we will be looking at fixing this fracture.
Yeah, pre-COVID, we would fix this fracture, and it is a lengthy operation involving more than one incision. And the idea is that the patient would have to be anesthetized for this lengthy procedure. And that's probably quite a risk in these COVID times.
So with the whole informed consent process, we had this discussion with this patient, and this is a real case that came to our hospital, and we discussed it at our 8 o'clock trauma meeting. And in essence, all of us felt that this kind of complexity, and with the added risk of developing COVID in hospital, when we put it to the patient, we actually went down the non-surgical route initially, treated it with a plaster initially just to help stiffen this up, keep the alignment, and then convert to a range of motion brace to allow that early knee range of motion. And then the plan would be with her essentially to do a delayed complex primary knee replacement. So accepting that it's not the perfect scenario, but at least it takes us out of this acute phase. Now we know a little bit more about COVID. We've started elective surgery and relatively safely. And there are actually, fortunately, not that many incidents of COVID, certainly in our institution, post-surgery. And therefore, our plan will be to let this heal up and then do a complex primary knee replacement. Any other comments on that, Harold?
Yes, I agree. And I think if we look in the literature, the results are actually quite complementary for those who have a joint replacement procedure. At the age of 63, there's a risk that the patient will have multiple procedures if we went down the plate route. However, with the COVID times, I think that it's just weighing the risks and the benefits, and the patient has the choice of deciding which path they want to follow. This is a very sensible patient, and she felt that it was wise to continue down the non-operative route. And we will keep an eye on her and our patients on a regular basis.
Okay, excellent. So we're now going to move on to the spinal trauma with Mr. Rajiv Bajekal.
Thank you. So if I can share the screen. Has that come up for everyone?
Yeah.
Yes.
Okay, so just to give you a little bit of the story, this was actually at the peak of the COVID crisis, or rather the first 10 days or so, when the ward was rapidly filling up with COVID patients. This was a very fit 60-year-old lady who was crossing a pedestrian crossing, and a car didn't stop. She was tossed up into the air, landed on her bottom, and quite surprisingly, the only injury she had was to the spine. So I'll let Dr. Anwar describe the X-rays for you. She had no other comorbidities, and she came up with this fracture.
Okay, thank you very much, Mr. Bajekal. So on the left here, we have an AP view of the lumbosacral spine, and on the right, we have a lateral view here. What we can see here on the lateral view first is that we can count from the bottom and see that there's the fifth lumbar vertebra going all the way up, and they're all the same shape. They're all a nice square or rectangular shape until we get to T12, which is this one here. And you can see that the superior end plate there is slightly depressed, and so the shape of that vertebra is a bit more trapezoid. There's a bit of loss of height anteriorly at the front compared to the back and compared to the others. So we know there's a fracture there at T12. On the AP view, what we look for here is whether there's any displacement of the pedicles. So the pedicles there are those two little circles there on either side. And often when you have a crush fracture, what happens is, and with the posterior elements involved, the pedicles get displaced apart. On this particular case, it doesn't look like they are displaced, but obviously this would warrant further cross-sectional imaging with CT and or MRI.
Okay. Got a bit of a problem. It doesn't seem to want to move.
So if you click back onto the presentation, there we go.
Yeah. Okay.
Perfect. So here we have the CT scan, and CT is excellent for looking at bones and for fractures in particular. It gives us a lot of information. In this particular case, you can see that T12 fracture there with the loss of the height anteriorly, a little bit of kyphosis at that site. You can see whether there are any bony fragments indenting the spinal canal, and you can see there is a slight bulge there, but probably you can't see the spinal cord there, so you can't tell whether there's any significant compression. But the main finding from this is that fracture and the degree of the depression there of that fracture and the loss of height, which will inform further management.
Yeah, I mean, from a spinal surgical point of view, we really are worried about fractures which are at the junction of the thoracic spine and the lumbar spine, because these patients can tilt over very rapidly and their kyphosis can progress. So we really want to get to know about the stability, and we find that one of the other useful investigations is this one, actually. So Imran, if you don't mind describing.
So this is a stir sequence MRI scan. So stir sequences are designed to make everything dark on the scan other than fluid or edema. So you can see with that T12 vertebra, there is bone marrow edema, this white area here. When you compare it to all the others where it's all dark, that white area indicates bone marrow edema. And you can see the extent of the fracture. The bone marrow edema indicates that the injury is going all the way through that whole bone, including the middle column there as well. A key finding on this scan is the edema that you can see in the interspinous ligaments at the back there. So you can see that is slightly brighter there than the other levels. And that indicates that the injury is actually extending all the way through to the posterior elements as well, which makes this a significant burst fracture. And the fact is that this indicates that it is unstable and is likely to get worse. On the axial view, of course, we can see the spinal canal. You can see a little bit of that bone encroaching into the canal, but not particularly threatening that spinal cord at this moment in time. But as I say, because it goes all the way through, this fracture could continue to collapse and the patient could get a worsening kyphosis and potentially also to affect the canal.
Yeah, absolutely. And so our major concern was we wanted to get her mobilizing, and we did try without an operation because we had read that very paper that Joyti quoted at the beginning, which was in the Lancet, which gave us a morbidity, a mortality rate of 20% or so with the general anesthetic. So we tried to avoid an operative situation, but in the presence of an unstable fracture, this can be tricky. So Giles, if you don't mind, can you put up our first poll just to get an idea of what the audience think?
Yeah, so how should this fracture be managed? Do we rest until healing occurs and then mobilize? Do we brace or do we stabilize with pedicle screws, 2 above on each side and 2 below connected by rods? So 40% of people have responded to that. We'll leave it up for a little while longer to allow people's answers to come through. If you do have any questions, please do put those through the Q&A function and we can put those to the panelists tonight. We're up to about 70%. And I will stop that there and then just share those results with you. So you can see that 4% suggested rest until healing occurs and then mobilized. 49% suggested brace, and then 47%, very close between those two, suggested stabilization with pedicle screws, 2 above on each, and then 2 below connected by rods.
Okay, well, that's close between the brace and the pedicle screws. We didn't obviously offer you the choice of what we did, but this was after a big MDT discussion. Just to give you an idea, a brace is a very reasonable option, but it doesn't really improve the pain to that degree. It's more effective, I would say, in the slightly more stable injuries. And you either have to let them be in bed for a bit till they get truncal control and the fracture glues up a little bit, then the brace is more effective. Also, the pedicle screw option can take up to 3 to 4 hours for an operation. So it's a really long, complex operation in the time of COVID when nobody wants to really get exposed to that viral load. So after much discussion, we decided on this very innovative technique, which we haven't really used in an acute fracture before. But as you can see, these are percutaneous techniques. And it is, we just put in a guide wire, and over that we can thread in this device, which is a very innovative device. It's called a spine jack. And it's exactly like a car tire jack. You know how you change your spare tire if you get a puncture. So it's exactly like that. It's got a plate on top, and when you expand it, so you literally wind it up, and it changes the shape of the vertebra back to almost normal, as you can see. And we have to use bone cement, which is what this radio-opaque shadow is. And we inject that through the tube. So they're 2 tiny incisions. The whole operation takes 45 minutes. But the real risk is because it's an acute fracture, cement can leak into the spinal cord area. So you really have to keep screening live. So we have this device called an image intensifier, where we can take rapid X-rays very frequently without the same level of exposure. So this patient had this done and literally walked out the very next day without any problems. Yeah, this was just to give you an idea of what can be done with this innovative technique. Thank you. I'll stop sharing at this point.
Perfect. Right, so that was the spine case, and just remember these are real cases that are presenting to our trauma rooms every day. So we're now going to move on to our third case, which is Rupen Dattani talking about a proximal humerus fracture. Rupen, over to you.
Thanks, Joyti. I hope you can see the screen.
Yeah, we can. Yeah.
Good. So once again, this is a case that I saw in April. So you can remember April was where it was the height of the pandemic. We had our ICUs were completely full of patients with COVID, and we had very minimal access to theatres because what had happened is most of our theatres were being used as makeshift ICUs because of the ventilators that we had on them. So we had access to one theatre for all subspecialties. So there was a big vogue towards treating most patients non-operatively, and in fact the BOA guidance was try and treat as many patients non-operatively as possible. So this is a 64-year-old woman who fell at home. She lives alone, and her past medical history is hypertension and type 2 diabetes. Now these are quite relevant because these were the cohort of patients in that Lancet paper, which has been alluded to earlier today, who were deemed to be at the highest risk from just COVID itself, let alone from surgery. So what she had was this fracture, which had been treated non-operatively. So we had two weeks of where 2 weeks of her being treated non-operatively in a collar and cuff and subsequently in a sling. But she was coming back for regular reviews because of pain. So Imran, would you like to comment on these?
Yes, certainly. Can you see my pointer here that I'm moving? No.
No.
Okay. Let's just.
Yeah,
okay.
it's come now.
Okay, great. So here we have an AP view and a lateral view of this patient's left shoulder. So this is the glenoid here, and this is the humeral head here. You can see that the glenoid and the humeral head are still articulating as per normal. But what we can see here is when we come down to the metaphysis here, there is an obvious fracture. So there is a break here. You can see that the metaphysis and the shaft has impacted. So it's gone into the head there. We can see that the shaft here is medialized, it's gone medially there, and that could be a problem and could affect further management. On this view, you can perhaps get the inkling of perhaps a loosened line going through this area. This is the greater tuberosity where those important tendons, the supraspinatus, attaches there. So this looks like it's probably a fracture going through here and then one going through here. So probably a three-part displaced fracture of the surgical neck of the humerus. And you can see the angulation on the lateral view as well, where this is going up and then it suddenly goes off in that direction. So this would normally require cross-sectional imaging to evaluate it further.
Well, thanks, Imran. So I totally agree. So in most cases, we would have got a CT scan here, but the problem was we were trying to minimize people coming into hospital for sort of procedures and investigations at that point in April. So she came back for a follow-up clinic and was just absolutely struggling in terms of pain management. So we spoke to her about having surgery. And in most cases, what we would do here is you want to realign the shaft of the humerus back onto the humeral head and hold it in place with a plate and screw construct, essentially known as open reduction internal fixation. But this would involve sort of a general anesthetic, having the patient sort of in a beach chair position for about 2 hours or so. And again, we had two problems. One was limited access to theatres, and secondly, she was deemed to be relatively high risk in April in terms of having a surgical procedure. So I don't think we have a poll here, do we, Giles?
No, we don't have a poll in this.
Rupen and time. So what we tended to do, so we had an MDT meeting with our anaesthetist, and what they were happy to do was to give a regional block. So this is essentially a nerve block injected around the neck, so to try and sort of numb the whole of the upper limb in order for us to do a smaller procedure to try and stabilize this fracture. So what we did is did this procedure whereby just through a very small incision around the deltoid, like a 2 centimeter incision, we introduced 3 wires along the humeral shaft into the head to try and stabilize this fracture. So as you can see now, the previous shaft, which had medialized, has now gone back and it's sort of aligned with the humeral head. The greater tuberosity fracture here, which you can quite still clearly see on the intraoperative images, we left alone because it's not something that we could have tackled with these wires alone. But the decision was made that we were trying to do what's minimally invasive for her. So this was like a 20-minute operation done under a nerve block whilst the patient's awake. And what we did is 6 weeks later, we took the wires out under local anesthetic. And as you can see now, the humeral shaft, which is medialized before, is now in congruity with the humeral head. And the greater tuberosity here is also healed. So, you know, COVID, in terms of sort of changed the way we treated this fracture. More conventionally, what we would have done would have been a plate and screw construct. Thanks.
Okay.
I had a question on the spine that was asked, whether we should remove the spine jack. And the answer to that is, once it's enmeshed in the cement, it's virtually impossible to remove it. So we don't really do that. And it doesn't seem to make a difference if you leave it in there.
Just for Rupen, really, what was the plan for the wires?
So we took the wires out because you can't leave the wires in, and the reason you can't leave the wires is they impede sort of the deltoid functioning. So, you know, as soon as you elevate your arm, the wires will impede. So the wires we took out under local anaesthetic, you know, so both procedures were done as a day case procedure. And the patient went home after having the first procedure. She was in a sling, but a lot more comfortable because the fracture was more stable. And interestingly, having the wires in does allow a little bit of movement, and therefore they form quite a lot of callus quite early on.
Excellent. Okay, so we're going to go to our fourth case now, which is Pinak Ray, and it's an Achilles tendon injury.
Hi guys, Pinak Ray. Thank you very much for inviting me for this, and I'm privileged to be here. Thank you. Today I'll be discussing a very simple case, but how things can change your management during the COVID period. So this 35-year-old gentleman missed the curb. He was in one of his once a day walk, as Boris had mentioned, and unfortunately had an injury. And he came in limping, and you can see from this picture how on the right side the tone of the Achilles tendon is lost. Although you can see the contour of the Achilles tendon, you can see the tone is lost as compared to the left side, where there is about a 15 degree of plantar flexion. When we palpated the Achilles tendon itself, you could palpate a gap, and it was in the middle of the Achilles tendon. This poor gentleman had torn his Achilles tendon, but he's 35, he's very fit, but has had history of tendonitis in the past, and therefore that sometimes can make someone more vulnerable to injuries like this. This is an ultrasound scan, which is very difficult to get, but Imran, can you tell us something about it?
Certainly, Mr. Ray. If you could kindly do the pointing for me as I describe the findings. So this band here at the top here, which is between those, so that's the subcutaneous fat that Mr. Ray is pointing at there.
No.
Just below that, you can see there's a band where those crosses are. So that layer, you can see all these different layers on ultrasound. Where those crosses are, they indicate a tear. This should all be a continuous sort of grey band, which is the Achilles tendon. And you can see that the dark areas there are hematoma. So that's where it's bled. You can see the degree of retraction of the tendon, a little bit of the tendon that's sort of retracted distally. The important information that the surgeon wants to know from this kind of scan is, you know, the site of the tear, whether it's a muscular tendinous junction tear or whether it's in the middle of the tendon, which would change management, whether the two torn ends can come together or not. And that's why ultrasound is perhaps better than something like MRI or cross-sectional imaging, because it's a dynamic scan. We can move the foot into plantar flexion and dorsiflexion and see how much of a gap there is and whether those ends are coming together or not, which is invaluable information for the surgeon. But this is a clear full thickness tear of that Achilles tendon.
Thank you, Anwar. Okay, so this was a full thickness tear, and you can see in plantar flexion there is still a gap. Can I have the poll, please, Giles?
Yeah, there's a two-part to this. So what non-operative management would you suggest for this patient? Would it be equinus plaster followed by a boot and wedges? Would it be a walker boot with wedges? Or would it be a range of motion walker with adjustable hinge? For the second question, which operative management would you suggest for this patient? An open repair or a percutaneous repair? So we have about 25% of people have answered. It always takes a little bit longer with the two-part questions. We're now up to 50. I'll just leave that on for a little bit longer, allow those answers to come through. So we're almost up to 70%. And then I'll end that there and then share those results. So you can see what non-operative trip management would you suggest for this patient? 53% have gone for equinus plaster followed by a walker boot with wedges. 39% have said a walker boot with wedges. And 8% have said a range of motion walker with adjustable hinge. For the second part of the question, which operative management would you suggest in this patient? 32% have said an open repair and 68% have said a percutaneous repair.
Excellent. Thank you. I think the answers are amazing, and I'm going to talk about it. Now, because of the COVID period, we were in a dilemma. Normally, with a 35-year-old gentleman who is otherwise fit and healthy and wants to carry on with his sporting activities in the future, of course, we can treat Achilles tendon tear both ways, operatively and non-operatively. But my preference for a patient with this profile is usually a fixation. However, because of the COVID period, we were unable to get a theater. There was a possibility of sending these patients off to another hospital that was supposedly a green hospital and were doing our trauma. But when we send the patients over to that hospital, they refused to entertain an Achilles tendon repair. And therefore, the patient had to come back, and we decided to treat him non-operatively. And I gave the three options because non-operatively, the treatment of an Achilles tendon non-operatively does not mean that we put the patient in a plaster and forget about them. Literature says that non-operative treatment is actually as good as operative management. However, then in the non-operative management, they need to be managed very meticulously. And accelerated rehabilitation is what has been shown to be excellent and almost equal to an operative management. However, getting accelerated rehabilitation is not possible in every department. You have to have dedicated physiotherapists for it. And not everybody can, not every department can have it. And therefore what happens is we treat these non-operatively by putting them in an equinus plaster for a long period of time, and then put them in a boot with wedges for a long period of time, rehabilitation and weight bearing a bit late, and they end up with, yes, a healed Achilles tendon, but with possibility of re-ruptures when they go back to their sporting activities being very high, and literature says sometimes between 5 and 20%. My preference for non-operative management usually is very early weight bearing, accelerated rehabilitation. If the patient is in a lot of pain, then I would put them in an equinus plaster just for 2 weeks, and then put them in a boot immediately after with wedge, and allow them to bear weight, because it has shown that the patient satisfaction is excellent, healing time is less, rehabilitation can be started early, and getting back to sporting activities is also early.
Pinak, if you double click on the image, you can move it on if you wanted to show the percutaneous.
So, I mean, normally, this is what I would do surgically. It's a percutaneous Achilles tendon repair. And I'm extremely pleased to note that the audience, about 68% of you who voted, said percutaneous. So obviously you have all seen these post-op patients. And I must say rehabilitation is so fast. They don't even need to be in a plaster. They can be in an equinus, in a ROM, range of motion walker, or maybe in an aircast boot with wedges immediately after surgery. The wound heals up in 2 weeks. You can start them on rehabilitation, and the results have been shown to be excellent. And this is one of the things that we prefer to use. This is an ROM walker. You can see there's a hinge, and this hinge is excellent. It's very easy to change the dorsiflexion and the plantar flexion. We start with plantar flexion, and very soon over 4 weeks, we bring them back to neutral. And the results are excellent. Now, this gentleman was treated non-operatively in an aircast aircast boot with wedges, and I have seen him recently. He's doing very well, and during the COVID period, he had his first physiotherapy session, but it was virtual, and even that helped. And I think he's doing very well.
Okay, excellent. Thank you. Giles, I think there's a few questions in the chat that we've not been able to respond to. So do you want to go through those and then just answer them?
So if there are any other questions for any of the panel, please do send those through. There's a couple of questions for Mr. Dattani, first of all. So a question from Diane Shaw, just saying, with the neck of humerus fracture, do you think you had a better result than with plate and screws, even though it's perhaps not the technique that you would normally have gone for?
Well, certainly the post-operative x-rays look very good. I think in terms of alignment, we've been able to sort of achieve alignment. And she, at the 6-week follow-up, which was around sort of mid-May, June, early June, she had a fairly good range of motion. So, she could sort of elevate to about 100 degrees already at that stage, and just got ongoing physiotherapy. So, yeah, possibly she may have had a better result. And I think COVID, one thing COVID has taught all of us is sort of novel ways of trying to treat fractures, which we may have not routinely done. So, I think some good's come out of COVID, I would have thought.
Okay. And there's a question from Zoltan Kirali. Did you leave the nails outside the skin, or did you bury them?
No, I buried them. And the reason I buried them was I was slightly worried about infection, because the last thing I wanted was this lady then to get an infection through the wires back into the bone and develop an osteomyelitis. So I buried them, and that's why she had to come back. They were fairly prominent under the deltoid, so they were quite easy to take out under local anesthetic.
Okay. All right, thank you. And then a question for Mr. Ray, so from Alex Sedgwick. If you had more guaranteed access to physiotherapy, would you choose non-operative management more often, perhaps?
Yes, sir. Yes, I agree. If I had the accelerated physiotherapy in my department, then I would choose non-operative management as well.
Okay. That's certainly very interesting, and it kind of moves on to a question from Miss Gilmore. It's just saying, will you change your practice now theatres are more readily available? And I think that's kind of to the whole faculty, really. Do you think this has informed the way that you will intend to continue from now on?
I think, as Rupen said, COVID has made us think slightly outside the box and do things differently. I think, you've always got to have that conversation with the patient. It is very much informed consent. There are pros and cons for, each of it, whether it's, managing it non-surgically or assisted non-surgically with, devices such as braces or orthotics, etc., or the risks, that are attributed to surgery. The one thing that surgery does is usually allow a stable fixation and early range of motion. And that's what we aim for. That's generally the principle of fixing most things to get patients up and out of hospital and mobilizing early. But as I say, our management was very much guided by, to coin a government saying what the science that was around at that time. I think since then, we're not seeing that much, COVID in patients that we've operated on. I'll be honest, I'm not really sure. I don't know if any other panel members can comment on that. We've seen these statistics of 20% mortality, but it doesn't really equate in practice. And it may be just that we're through the sort of the main part of the COVID, and we're not necessarily out the other side, but we're not in that environment where you've got COVID, just patients in and around the hospital.
I think, Joyti, a couple of things. I think the paper on the Lancet was obviously a multi-center, multinational trial.
That's right.
Different parts of the world where they were in the different phases of the pandemic. The other thing is, in most trusts in the UK, patients were being swabbed for COVID, right? And then being offered surgery. So, it took 24 to 72 hours to get that result. And we were only operating on patients who were COVID negative. Anyone who was COVID positive was definitely told that they had to go down the non-operative route. So I'm sure that helped reduce sort of the rates of post-operative COVID or, perioperative complications.
Rajiv, what were your thoughts on that?
Yeah, I mean, we really haven't seen the Lancet paper, the kind of despair, the horrible results there. But I think Rupen's right about it. But I just wanted to make a general comment about the fact that, COVID has brought some good. I mean, in the past, to get an MDT opinion of 4 spinal surgeons would have taken me 2 or 3 days. But somehow IT got revolutionized overnight, literally. And within 3 or 4 days of the epidemic hitting us, we were all able to get home access, and you could literally share images, which otherwise people would have said something about data protection or some other ridiculous thing. But in the interests of patient safety, in fact, which overrules everything, we were able to get opinions from a variety of places, even from surgeons who were sitting at home. So it was really quite easy to do that, and it kind of focused the mind on the job that was to be done.
Just a question for Imran, really. Sorry, Harold, I'll come to you in a second. But with the imaging side of things, Imran, that was one of the sticking points, with patients that were query COVID, often, for 12, 24 hours, not being able to use scanners and that sort of thing, not being able to get all the information. How do you feel that was handled?
Yeah, I mean, it certainly had a big impact on our practice because, patients who were suspected of having COVID, if they were scanned on a scanner, that scanner could then not be used unless it was deep cleaned, which was a lengthy process, and then before the next patient could be scanned. And the difficulty was that the tests for COVID weren't sort of an instant sort of test. So patients who came into A&E and needed a scan straight away, it was difficult to say whether they had COVID or not, because many of them were asymptomatic or had a very mild sort of symptoms, may have been COVID, may not have been COVID. It was a very difficult decision. So what we had to do in our particular hospital was to divide our scanners up. So one was considered a sort of dirty scanner, so to speak, where anybody who had any possibility that they might be COVID positive were treated in that scanner, which was done at a much slower rate to clean the scanner in between. On another note, COVID has obviously affected musculoskeletal radiology services quite heavily, because a large part of what I do is performing steroid injections, intra-articular steroid injections, and there has been some research which in the past has suggested a sort of increased susceptibility to influenza-type viruses like SARS and like COVID, and that's why we have been very sort of careful to try and avoid performing steroid injections, particularly in high-risk groups, and that's starting to change. We are slowly reintroducing COVID injections, but we're still, having to be very, very selective in who gets an injection and who doesn't, because you don't want to needlessly reduce people's immunity in the current climate.
Okay, Harold, what were your sort of final thoughts on this?
I just wanted to add that, as in Total Orthopaedics, it's a real discussion with the patient and the journey, and the patients are given the facts, and we respect their opinion. Patient safety is paramount. And for these cases that we discussed, it was very key that the patients knew what we were actually trying to get across, and that safety was going to be the most important aspect, and that their management and long-term outcome should not be significantly diminished. And I was quite pleased to be involved with the management of that particular complex knee case. And I did quote some references regarding what happens with the management of these complex fractures in the mature patient. So it's quite good to have that discussion with them.
Good. Giles, I think there's a few more questions coming.
Yeah, so just how are you dealing with the backlog with regard to MSK steroid injections? So I believe Dr. Anwar was talking about this briefly, but how are we going about managing that situation?
Yeah, I mean, it's a very, very difficult problem to treat because we have literally a couple of thousand MSK requests that were all sort of put on hold when lockdown started. And we haven't been able to do because we've been prioritizing first COVID scans and then cancer scans as well. And we have much more reduced capacity because our waiting areas can't be packed full of patients waiting as they were before. We have to clean scanners in between. So the steroid injections, what in our particular trust, what we're doing is we're sort of writing to patients and sort of trying to prioritize them. So there are many people, because it's been many, many months, who either their symptoms may have resolved, they may have had other therapies, they may have had physiotherapy that may have improved things and they may not need the injection anymore. There are some patients who may not want to have the injection in the current climate when they're made aware of the potential risks to their immunity, even though it's a very small and perhaps theoretical risk. Some patients don't want to proceed, and so we don't want to needlessly send them appointments and take up slots in that regard. And we're also asking clinicians as well to prioritize requests. So clinicians who've sent cases or referrals to us, we're sort of asking them to re-look at some of those referrals and see, does this still really need doing, or has the patient had something else in the intervening period that has resolved their pain? And so
there's also
avenues here.
Just to come in on there, there's also the options of not just using steroid, using other agents, either if it's let's say for arthritis, hyaluronic acid, although one can, debate about the merits of that, but also the newer sort of biologic therapies such as platelet-rich plasma or platelet-derived growth factor, often not always available through NHS, options, but certainly there are options out there.
Okay, fantastic. There's also another question is, do you now have COVID clean and dirty theatres for trauma? It's from Akib Khan. I believe we've already covered the second part of his question.
Yes, well, we do have dedicated COVID dirty and clean theatres. We for the first time for trauma, we are running 2 theatres now. It's one theatre list, but in 2 theatres. It means that we do a case in one theatre and then move to the other theatre so that the first theatre can be cleaned. And this is something that has just started immediately after COVID. And if there is a COVID positive patient who needs a fracture fixed, then it's done in one of the theatres while the clean ones are done in the other theatre.
Just one thing to add, I'm not sure whether the audience know, but it just takes a lot longer to do cases now, purely because patients who would routinely be anesthetized in an anesthetic room and then be taken into the operating room and then have a surgery, that's no longer being done. So patients have to go into the operating room, be anesthetized there, and then there's a lag period before you can actually start the procedure. And similarly, once the patient is extubated, there's a bit of a lag period before they come out. So everything just takes a bit longer, hence the need for 2 theatres so you can actually run the similar number of cases. But that is sort of labour intensive because you need twice as many anaesthetists and sometimes twice as many surgeons to carry out the same number of procedures.
How have you found wearing, if you're doing a query COVID or a COVID positive patient, wearing the sort of full PPE? Has that, affected your sort of dexterity or vision or anything like that?
Yeah, I find it very difficult, especially with the face mask, because they kind of interfere with your surgery, and therefore I've stopped using the face mask now. I use goggles, which are slightly better, but yeah, it is a hindrance. And if you have a case which is 2 hours plus, then it becomes really difficult.
Yes.
Yeah, I mean, with spinal surgery, we already have goggles or loops. And then you have this NP95 mask, which fogs it up further And then on top of it, you have this hood on top. So it really does make it, you know, I sometimes wish I'd invented a wiper for the lenses, because it does get quite foggy and claustrophobic behind 3 layers of glasses if you're not used to it.
There's something for our Össur colleagues to develop around.
Yeah, something non-foggy.
PPE is not an area we've gone into, but it's certainly an interesting thing for our R&D department to be aware of. So I think that's all of the questions for here this evening. If you have any more questions, do please send those through. We will pass them on to the team after the session. It really remains for me to say thank you very much to the team at Total Orthopaedics. Really interesting discussion between the different specialisms about the situation and what they're actually doing to manage their patients given the current situation. So I have to extend my thanks to all of the team for their input this evening. Really remains for me to just discuss the next session. So the next session is in 2 weeks on the 22nd of July at 7 p.m. It's about diabetic foot management, an MDT approach. We'll be joined by Gail Morrison, who's clinical diabetes team lead for NHS Glasgow, Greater Glasgow and Clyde. So really interesting topic. So Gail Morrison is an orthotist by background. So a really interesting insight into how the system is set up. So thank you very much to the team at Total Orthopaedics. Really appreciate your work this evening. Fantastic presentations from you all. And we hope to see you in a couple of weeks.
Thank you very much, Charles.
Thank you for having us.
Bye.
Thank you for having us.
Thank you.